Hi, good day, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation to the series that we have started, What Surgeons Should Know. And today we are going to talk about lower GI endoscopy. And as a brief introduction to this lecture, in this lecture we are going to talk about different endoscopic technique, diagnostic or treatment that we have to know when dealing with the lower GI complaint. And we have to recognize that lower GI endoscopy, such as anoscopy, proctoscopy, is part of the physical exam. It's an extension of the physical exam, not a separate entity. So it's important. This lecture means for me a lot because, first of all, it's one of my colorectal interests. I will explain for you what do I mean. Surgeries start in the past as an open surgeries, open whatever, colorectal surgeries. Then we move step forward to laparoscopic surgeries. And if we want to move step forward, we are talking about endoluminal surgery, which is performed by endoscopic technique, the different endoscopic technique, proctoscopy, anoscopy, sigmoidoscopy, flexible or rigid, and colonoscopy. So we are going to review these modalities of diagnosis and treatment. Okay. We are going to talk about in details about colonoscopy, the modalities of bowel preparation, and the complication associated with colonoscopy, how to deal with incomplete or difficult lower GI endoscopy. So we are going to review these details. To start with the endoscopic approach, we have to learn how to perform anorectal exam properly. Okay, before proceeding, as we said, before proceeding to any endoscopic procedure, we have to perform proper anorectal examination. Whatever, if we are going to perform colonoscopy, sigmoidoscopy, anoscopy, proctoscopy, we have to start by anorectal examination. And the first step is taking proper detailed history. Okay, the history will help me in, first of all, it will guide my exam and it will reduce the anxiety of the patient. Of course, you are going to perform an anorectal procedure, so there will be some anxiety. The preferable sequence is to talk with the patient and to leave the room to give time for the patient for proper positioning with the assessment of the medical nurse and to come back. So it's not preferable to be with the patient while positioning. This will reduce the anxiety and preserve the patient modesty. Okay, a chaperone is essential while performing the anorectal exam, and also the room you are going to perform the exam should be well equipped. For example, as you see in front of you, we have a portable light source. We should have a portable light source. We should have a toilet nearby, and the instrument should be ready for the use. If we are talking about the patient position, okay, we have two positioning while performing anorectal exam. The first, as you see, is the prone jackknife position, and it's an excellent better than the second alternative position, the left lateral position or Sims position. Actually, jackknife position provide better visualization, and also it's easier to perform procedures such as endoscopy, proctoscopy, and hemorrhoidal banding. But it's not available in all patients because the table may be not available in the exam room to actually bend the table and tilt the pelvis up. This is one of the causes of why we perform the left lateral position. And also some relative contraindications such as decreased mobility, recent abdominal surgery, morbid obesity, late pregnancy. These are, we can say, and some arthritic condition that affects the knee, hip, and lower back. So it makes the jackknife position more harder. Actually, the left lateral decubitus or Sims position, as you see in this picture, actually this is not the 100% correct position for anorectal exam, because the buttocks should extend. As you see, the buttocks should extend out over the edge of the table for a shorter distance to facilitate the anorectal exam. And if you are using the endoscopy, you want to rotate it, so the pelvis should actually be extended over the edge. Okay, and also in this position, as you see, the hip and knee are flexed 90 degree. You may need an assessment to actually retract the right buttocks, especially if you are examining the anterior perineum. Okay, we start with, we said, history, positioning, we move to inspection and palpation. Okay, we take history, talk history, position the patient, we move to inspection and palpation. It's mandatory to have adequate lightening, and also we may need, as we said, some retraction of the buttocks by an assistant, especially if we are talking about the left lateral decubitus. Inspection, actually, many conditions can be noted in inspection before proceeding to endoscopic technique, such as pilonidal diseases, any lesion in the anal margin or anal verge, hemorrhoidal disease, also skin irritation, ulceration, erythema, drainage site if we are talking about fistulas, candyloma, scarring or evidence of prior anorectal surgery, purulence, fecal soiling and anal discharge, prolapsing tissue. The appearance of the sphincter at rest should also be noted. And actually, commonly in the anal clinic, we notice the patulous anus, or when the mucosa of the anus and rectum is protruding out, and this may indicate incontinence or prolapse. Before ending your inspection, you may ask the patient to perform a Valsalva maneuver to increase the abdominal and pelvic pressure, so you can also notice if there is any degree of perineal descent or rectal prolapse. You can also perform what we call the anocutaneous reflex or anal wink. Actually, this is just light touching of the skin near the anal verge will cause actually constriction of the anus, so it's absent in some spinal cord injuries such as cauda equina. The palpation, we can notice tenderness, induration, fluctuation, which may indicate any suppurative process. A gentle actually effacement, just a retraction of the anus a little bit, you may notice the fissure posterior or anterior. It's preferable to document the location of any lesion according to the anatomic position, anterior, posterior, right, left. It's better than using the clock face description. I know that we frequently use the clock face description. For example, 12 o'clock, 3 o'clock, 6 o'clock, but it's better to say anterior, posterior, left, right, lesion. Okay. Digital rectal exam. Okay. Digital rectal exam, as we said, the clue to the digital rectal exam is the communication with the patient to decrease the anxiety. Any pain or discomfort will make the exam more difficult and less information we can have. And also, the willing of the patient in the future to repeat the exam will be also decreased. Of course, we have contraindication to digital rectal exam. This include, for example, anal fissure, thrombosed external hemorrhoid, non-reducible internal hemorrhoid, tight anal structure or anal stenosis. Even the little finger cannot be passed, and also large, huge anorectal mass. Classically teaching that the neutropenia may cause spread of the infection during digital rectal exam, but this is theoretically. We have a little data to support that, so we can consider neutropenia as a relative contraindication. As you see in this picture, this is a doctor actually and a simulator, and he is trying to train how to do anorectal exam, digital rectal exam. Actually, first of all, we start by lubricating our index finger, and actually, if we have a little bit resistant at the beginning of the exam, gentle pressure to the anus may relax the anal sphincter. If we have a stool, we have to document its consistency. Okay, it's important also to notice the sphincter tone at rest and also after squeezing, after asking the patient to maintain the continence. Some patient with underlying sphincter problem, they will actually use compensatory mechanism to maintain the continence. Let me show you where it's here. Boom. You see here, patient with an underlying sphincter dysfunction actually depends on compensatory mechanism to maintain the continence. This by actually squeezing their buttocks rather than the sphincter. These patients actually will have chronic constipation, will have abdominal pain, and actually you have to coach the patient how to depend on the sphincter mechanism rather than the pelvic muscle and buttocks. And you may proceed to biofeedback. We already discussed in this therapy, biofeedback therapy, in a separate lecture. Actually, it's just training the patient how to use their pelvic muscle well. Okay. After that, we start with circumferential sweeping of the anus and rectum to notice any mass. And if we have a mass, we have to document its size, mobility, firmness, relation to the anal verge, anorectal ring, and surrounding structure. Posteriorly, you may notice even not rectal but retrorectal lesion, and presacral lesion can be determined. Anteriorly, in male, you can actually palpate the prostate, and you may notice a high riding prostate, which indicate a trauma to the ureter, and the cervix in female anteriorly also can be assessed. Actually, also we have a bimanual exam. Actually, bimanual exam, this is for genitourinary problem in female. What we do for what we may need to do is examination of the what we call it the septum between the rectum and vagina, the rectovaginal septum. This is how we perform the rectovaginal exam. Rectovaginal exam. This septum may be teared, traumatized, fistulated, any lesion. This is how we can. Actually, there is a difference between bimanual exam and the rectovaginal septal exam. This is also can be done while performing digital rectal exam. Okay, what else we can notice also? Induration, induration, fluctuation. This is an indicator for any infection, as you see here. Induration, fluctuation, especially in abscesses that are not perianal. You can, if you remember, some anorectal abscesses are detected only after performing digital rectal exam. Of these, for example, the submucosal abscesses. So it can help us if we found induration or fluctuation. Any cord or a firm cord, fibrous cord, may indicate fistula while performing digital rectal exam. Also, asking the patient to do Valsalva maneuver, increasing the intra-abdominal and pelvic pressure, will help us to reach more proximal, to allow more proximal lesion to descend so we can detect them. Also, by digital rectal exam, we can, at the level of the anorectal ring, we can notice the levator ani muscle posteriorly, and if there is tenderness, levator ani syndrome can be established. We have a reflex if we touch the anorectal ring posteriorly at the level of the levator ani muscle, as rapid slight opening of the anus, and then it will reduce to its normal position. Okay, this is the digital rectal exam. Let's move to anoscopy. Okay, anoscopy is simple, inexpensive, outpatient, in-office procedure that can be performed. Of course, we have contraindication. It's similar to the contraindication we reviewed when we talk about digital rectal exam, such as fissures, thrombosed hemorrhoid, actually will make it uncomfortable for the patient. As you see in front of you, we have different type of anoscope. You can see here, this is a type of anoscope, actually I think called Figerson Hill or something like that. This is the classic endoscope we use. You notice this edge is beveled a little bit. This is the preferred, and if we want to talk about what is the best, is to use, actually we have disposable anoscopes with self-containing light source. It's the preferred, but actually some financial issue can face us if we want to use anoscope disposable. it consists of, as you see here, where is it? We have, this is the anoscope itself. This is what we call it, the obturator, and it usually contain a light source over here in which we connect them, or like this, it's have a self-containing light source. Okay, actually the anoscope doesn't require preparation or sedation. Okay, as you see in this picture, this is the right way to handle the anoscope before inserting it to the anus. You can see that the doctor is fixating the obturator by her or his thumb before inserting. If there is a resistance, so you can withdraw and insert it again. Okay. After inserting the anoscope, you remove the obturator and you start to examine each quadrant in the anal and rectal mucosa. But if you want to rotate or examine another quadrant, so it's better to reintroduce the obturator because the edges of the anoscope may cause tearing to the mucosa. Or alternative technique is to examine the quadrant separately by insertion and withdraw, reinsertion again. But the preferred is to keep the anoscope inside, remove obturator, inspect, put the obturator, reinsert the obturator again, rotate, remove, in order, as I said, not to cause any mucosal injury. Okay, what the anoscope can help us, we can, for example, document different pathologies such as internal hemorrhoid, polyps, candyloma, mass, mucosal inflammation, hypertrophied anal papillae can be performed. Also, biopsy can be performed of any abnormal mucosa or mass. Some therapeutic procedures such as hemorrhoidal banding and sclerotherapy can be done with no sedation, with no bowel preparation, as outpatient by using the anoscope. Complication may be related to the anoscopy itself, such as tearing of the anoderm and some bleeding, and may be related to the procedure we performed, such as the biopsy. It can cause pain or bleeding. So let's move to the proctoscopy. Okay, proctoscopy, we're still talking about rigid instrument. So it have advantage and disadvantage. When we move a little bit up, we start to talk about flexible sigmoidoscopy and rigid sigmoidoscopy. But proctoscopy is usually rigid. One of the advantage of the rigidity we have is that it gives us precise distance from the anal verge. We have it's not flexible, so the distance that we actually determine will be exact. So determining the precise distance from any region from the anal verge is precise. This is one of the advantage. Actually, proctoscopy, we are talking about the rectum. So the rectum is a site for storage of a stool. So bowel prep, unlike not bowel prep, preparation, evacuation of the rectum is preferable, unlike the anoscope, but sedation is not required actually. So we no need sedation, but we need some kind of rectal preparation. exploration. You can see in front of you the rectal scope. It comes in different size. It's usually 25 centimeter long, and the outer diameter also different, can be 19 millimeter, 15 millimeter, or 11 millimeter. This is a nice picture, shows you how the doctor is doing a direct visualization using the proctoscope. Actually, we have obturator like the endoscope, we have the air bladder. This will actually insufflate air in the beginning of the procedure, and we have a light source. Of course, we have also disposable type of the proctoscope. The proctoscope is marked with usually 1 centimeter interval, so the distance can be of any lesion can be determined from the anal verge. Okay, we can perform either we can use the proctoscope to describe certain pathological procedures, such as the anorectal procedures, such as rectal bleeding not explained by hemorrhoidal disease, proctitis, ulcer, evaluation of rectal mass. Sometimes we use it to pneumatic reduction instrument for volvulus. We can use it for diagnostic biopsy, and sometimes therapeutically for simple polypectomies. And also in cases of proctitis, if you remember radiation proctitis, we use topical formalin. Actually, we instill topical formalin using the proctoscope. Okay, the contraindication, actually, again, it's similar to the previously discussed contraindication to the endoscope and digital rectal exam. Of this is the fissure, bile, thrombosed hemorrhoid, stenosis, and recent rectal surgery. Unfortunately, actually, the rigid instrument is actually not preferable nowadays, of course, in the presence of the flexible instrument. So some surgeons and some endoscopists doesn't prefer the rigidity of the proctoscope. Okay, if we are talking about the technique, so we said first of all history, exam, and exam, either inspection, palpation, digital rectal exam. Then we actually lubricate, similar to the endoscope, lubricate the instrument, and we hold the obturator so it will be fixed, and we start inserting the proctoscope through the anal complex. Okay, once we pass the sphincter complex, we can use the obturator, we can remove the obturator and use our direct visualization to inspect past the sphincter. And direct visualization will help us to see where we are. Actually, it's better to direct your proctoscope posteriorly toward the sacrum. Also, as we end the rectum, stool may be present, so suction can help us to evacuate and remove. After suctioning and cleaning the area, we can use air inflation to distend the rectum a little bit, and this may cause discomfort for the patient, as distension of the rectum is one of the discomfort for the patient. Okay. What else? Direct. Okay. Of course, under direct visualization, as you see here, we can withdraw the proctoscope, redirect our insertion, etc. Up to 20 centimeter, the proctoscope can be inserted with no or minimal discomfort. The discomfort the patient may have usually related to two things. First of all, either the mucosa is, let's say, engaged in the edges of the proctoscope and there is a little bit tearing, or due to the insufflation of air in the rectum, the distension of the rectum can cause discomfort. Okay. Also, when you go back, it's called we will talk about the withdraw time. Go slowly as you go back and inspect. You may need to sweep the proctoscope right and left, up and down, to flatten the folds of the rectum. There we have the valve of Houston, so this movement can flatten the mucosa and to see what is behind these valves. If we notice any mass, we have to document the distance from the inner verge from the inferior edge of this lesion. Okay, as we said, biopsy can be taken even by snare biopsy, and before ending our procedure, we have to deflate the air we already insufflated, because this air may cause pain and discomfort. Complication to this procedure can be either to the mucosal tearing or due to the distension of the rectum by air, or by the this is if we are talking about pain, can be due to bleeding. Bleeding can be from insertion and tear in the anoderm or the rectal or anal mucosa, or also due to the biopsy or the therapeutic procedure we did. Bleeding post polypectomy can also a cause of bleeding. Okay, what else we didn't mention? Actually, this is a nice picture showing how the proctoscope can be reformed. Okay, let's move to endoanal and endorectal ultrasound. Okay, endoanal and endorectal ultrasound, actually they can be used as adjunct to the physical exam. They are part of the endoscopic modality for diagnosis. Actually, we can assess the anal sphincter complex, the pelvic floor muscle, and some diseases, and even anorectal neoplasm. It's extremely sensitive and specific in evaluation of the fecal incontinence, in which we can locate the sphincter defect with a specificity and sensitivity reaching 100%. Okay, if we are talking about endoanal ultrasound, so we can use it to figure out any abscesses or fistula, of course with the adjunct of insertion or injection of hydrogen peroxide in the external fistula, so visualization will be better. We discuss this issue when we talk about fistula. Endorectal ultrasound actually is used mainly for staging of rectal cancer, with limited accuracy for depth invasion and also for regional lymph node status. unfortunately nowadays the endorectal ultrasound is replaced by the MRI, pelvic or rectal MRI. Okay, as you can see here, this is how the picture will looks like. It's usually a 360 circumferential assessment if we are talking about the anus, and here as you can see the ultrasound probe. Here we have a tumor over here. So actually this is a 2D dimension. We can use the 2D dimensional imaging for anal ultrasound, and for rectal cancer staging it's preferable to use 3D dimension imaging for rectal cancer staging and 2D dimension imaging for assessing the anal sphincter in endoanal ultrasound. Okay, the frequency we use is usually between 3 to 20 megahertz, and basic biophysics information: the higher the frequency, the better the resolution, the less the depth of penetration to the tissue. So it may be with higher frequency it's best to assess more superficial lesion, and vice versa. The lower the frequency, the bad imaging, the more deep tissue we can reach. Okay. The endoanal and endorectal ultrasound, these are inexpensive, simple procedure, well tolerated, and can be used with in-office procedure as outpatient. But of course, if we are reaching the rectum, we need some kind of bowel preparation in a form of enema. Okay, the technique is similar to the endoscopy. Should be lubricated, and even the contraindication is similar. Any obstructing lesion in the anus or fissure or thrombosed bile, this will contraindicate the procedure. Okay, what else we can? Okay. Actually, reading the picture comes from the endoanal ultrasound differ from imaging that comes from endorectal ultrasound. In the anus, actually, the imaging that we can read is divided into depending on which location of the anus we are in. For example, in the distal anal canal, we can just identify the external anal sphincter, as you see in this picture. We said the endoanal ultrasound, usually two-dimensional endoanal ultrasound. You can see this arrow. This one is the external anal sphincter, and it's the only detectable structure in the distal anal canal. We know that the external anal sphincter is more distal than the internal anal sphincter. So distal is only the hyperechoic external anal sphincter. If we move up and we start to talk about the middle anal canal, so we start to see two structures: the external hyperechoic external and the hypoechoic internal anal sphincter. If we move up to the upper part of the anal canal, we still in the anal canal, we start to see the U-shape structure of the puborectalis muscle. This is, we are just in the anus. Nice procedure to determine any defect in the sphincter complex. Actually, it's extremely easy for surgeon who can perform and read, and extremely difficult for surgeon who is not experienced. In the rectum, in the rectal ultrasound, the issues differ. Actually, in the rectum, we have 5 distinct layers of the rectal wall, as you see in this picture. Actually, the white tissue is the tissue that is hyperechoic with high water content. And you see here we have, this is the endorectal ultrasound, and we have 5 layers. The innermost, this layer, is the interface actually between the ultrasound probe and the mucosa. A little bit inside here, the hypoechoic plaque, this is the mucosa, which is hypoechoic. It's over here. If we move a little bit outer, we start to notice the submucosa, extremely important layer to notice. This is the submucosa, which is a hyperechoic. If we move up a little bit, we start to talk about the muscularis propria. This is the muscularis propria, which is hypoechoic, and externally the 5th layer or the final layer is the hyperechoic rectal or perirectal fat. So the most important, I think, here to notice the submucosa, which is this interface. Where is it? This one. If by number, it's the 3rd layer, I think. Yeah. 1, 2, the 3rd layer, hyperechoic, this one, because if any neoplasm present, so the relation to the submucosa should be determined. We have a staging, ultrasound staging, abbreviated by U ultrasound, and T. T could be 1, 2, 0, 1, 2, 3, and we will see. You can see here, UT0 is a lesion, UT0 lesion, a tumor, which is confined to the mucosa. By definition, non-invasive, and it's not a cancer. This is UT0, and it's usually benign adenoma in a setting of endorectal ultrasound. This, you can see that the mucosa is intact, and here we have UT0. Actually, I think this is lymph node. If we move to ultrasound T1, so this is the tumor that invade the submucosa. You can see here the submucosa is invaded, and destruction of the tissue around is present. If we move to T2, so T1 is the submucosa, T2, that lesion extend into but not through the muscularis propria. Here is, I don't think that it fell in the interest of general surgeon to read, but I think it's nice to remember at least. You can see muscularis propria is intact, but not through the muscularis propria, not bind the muscularis propria. This is UT3 that extended through the muscularis propria. Sometimes it's giving a name scalloped appearance. This is UT3, and this is UT4 when we start to talk about invasion to nearby. It's extremely easy to read, but I think it needs practice. This is UN1. You can see that what we can see here is a lymph node over here. You can see here. This is a lymph node over here, lymph node over here. So, relative contraindication to endorectal and endoanal ultrasound, also similar to the previously discussed, including fissure, painful anorectal condition, stenosis, complication is rare, maybe related to the minor trauma that's iatrogenic. Advantages that it is easy to perform, relatively inexpensive, and of course we avoid the radiation exposure. The disadvantage that it is operator dependent. We move to the flexible endoscopic technique, and these are divided to flexible sigmoidoscopy or colonoscopy. Okay. Flexible endoscopy, here we are talking again about flexible sigmoidoscopy. Sigmoidoscopy can be rigid or flexible. Flexible endoscopy, flexible sigmoidoscopy or colonoscopy. And the differences between flexible endoscopy and what we already discussed, such as anoscopy, rigid proctoscopy, is that these are flexible material. So we will have difficulties with insertion, even with measurement of the distance of the lesion. So there are some techniques and, let's say, tricks that will help us in inserting these flexible materials. Unfortunately, flexible endoscopy is a procedure that you gain experience by doing, not by books. But of course, there are certain theoretical tricks that you have to know before proceeding to the clinical practice. As you see here, endoscopic technique is best learned by doing under a careful supervision of an experienced endoscopist. Okay, again, these are flexible instruments, so looping is common. We will understand what does looping mean, and there are some tricks to facilitate insertion and examination of the colon. Of these tricks is the Turk. Turk is the movement, circular movement, like this. As you see in this picture, this movement, while inserting, will increase the stiffness of the scope, so it can be inserted without looping, for example, and it will increase the resistance. Okay, this is one of the technique we can use. Another technique that we should know before proceeding to the procedure, that we have tip deflection. Actually, the image reflected in a screen, and the image that is reflected in a screen, the scope should be in the middle, in the center of the bowel lumen. And to keep this, we can use the deflection as you see in this picture. The tip of the scope can go up, down, right, left by controlling. You see this control unit. We have a wheel, two wheel, small wheel, big wheel, up, down, small wheel, left, right, and it's ideally to hold the control unit by your left hand and the scope by your right hand. So by your right hand you can do the Turk and dithering and jiggling, insertion, pulling, and by your left hand you are using the big and small wheel to control the tip deflection. It's better to perform by one person, to be a one-person procedure. Of course, an assistant can hold the scope and you will tell him push, pull, but it's better to learn it as a single doctor procedure. Other tip is the dithering or jiggle. Dithering and jiggle, this is the rapid movement, shaking in and out, rapid movement. This is dithering, and you can see in this picture, dithering will shorten the colon so that the final line, or what we call it, the finish line, will be proximal. As you see, the distal part becomes more proximal. This is because the haustration are more pushed together. This is called the accordion of the colon. This is jiggling, this is shaking. Other benefit that the scope can get stuck to the mucosa of the colon. By this rapid movement, it will get far from the scope itself. We use air insufflation while performing the colonoscope or sigmoidoscope, and air aspiration of the air we already insufflated is required also, because this will shorten the colon and make it better to advance. Of course, there is a calculated aspiration suction of air, but it's commonly missed. So air aspiration can bring the distal from the scope finish line more proximal. Okay. Slide by technique for insertion. Actually, this is a controversial, dangerous procedure. Should be done by experienced endoscopist. Actually, this is, as you see in this picture, used in area where is colon angulation present, such as the rectosigmoid, in the splenic flexure, the hepatic flexure, where you cannot directly by your eye see the lumen, so you blindly push the scope after maximal deflection of the angle, and you push it blindly near the colonic wall, so it will take the root of the colonic wall, and after it goes to the other side of the angle, you will see the resistance is lost. But this is extremely dangerous procedures and should be done with experienced endoscopist, and the perforation rate is documented. Okay, let's move and talk about flexible sigmoidoscopy and colonoscopy. Okay, flexible sigmoidoscopy, actually, it is, when we compare it to rigid proctoscopy, it's better tolerated and can be performed as an office procedure in office outpatient procedures. Plus, it gives you a magnification field. So this is advantage over the rigid proctoscopy. But actually, the exact measurements, or to be more precise, the exact distance of any lesion from the anal verge is better acquired from or taken from the rigid proctoscopy, because flexible sigmoidoscopy is flexible, can loop, can actually, so rigid proctoscopy is better for distant description. As you see in this picture, we have different size. We have here the length of the scope depends on the manufacturer. It could be from 60 to 71 centimeter, and the outer diameter from 12 to 14 millimeter, and can also be smaller. This is the adult scope, the diameter 12.8, pediatric 11.5, and even a slim scope can be 9.5 millimeter. This is how the flexible. It's easier to handle when we compare it to the colonoscope, but of course we will talk about the disadvantage when we compare it to the colonoscope. I'm interested just to tell you about some units in the flexible colonoscope. I remove this picture and bring it here just because I think that my picture is looking here. It may prevent explaining. Here we have the control unit. You see that direct visualization, it's not reflected on a separate screen. Of course, we have some manufacturers that can be connected to different screen, but with flexible sigmoidoscope we can directly visualize the lumen of the bowel. Here we have the eyepiece, we have the focusing ring, we have two bottom, one for the suctioning of the water, air, and other for air water bottom. Actually this bottom is like gradual bottom. You press and the max minimal insufflation and inflation, deflation of the water and air can be achieved. This is a control head. Actually, here we have a ring that we can control the stiffness of the scope. So if there is a certain part in the colon where the scope is extremely flexible, we can control the stiffness. I will show it to you in the next few minutes. Here you can see the biopsy channel. We can insert a snare or forceps from here and take polypectomy or biopsy. This is the inserting tube, the flexible shaft. These are the wheels. We talked about small and large wheel, up, down, left, right, and here a cord in which we get supply of water, air, and light. This is the distal tip, which we say that it could go up, down, left, right. Okay. Actually, by the sigmoidoscopy or flexible sigmoidoscopy, we can reach up to 40 to 50 centimeter. It's approximately to the level of the proximal descending colon. You see here, this is the sigmoidoscope, this is the colonoscope. The colonoscope, we can even go to the terminal area, but in the sigmoidoscope we can go up to the level of the splenic flexure by experienced colonoscopist, of course. Okay, it's not the preferred modality for screening. As you see, reaching the descending colon in about 80%. It's capable for detecting polyp in about 75% and colorectal cancer in about 60 to 65%. So it's not the ideal. Of course, it have certain indication we will talk about. Of course, it's easier than the colonoscope to learn. So we said it's not adequate for screening. Again, it's when we compare it to colonoscope, it's easier to handle. About the indication of the flexible sigmoidoscopy, as a general surgeon, we love this information. Actually, there are many indications of these are bleeding that is not explained or detected on anoscopy or anal exam. Also, level of the rectal tumor. Again, we said that it is less reliable when we compare it to the rigid proctoscope. Other indication is to determine the response of the neoadjuvant therapy for patient who is in a chemo radiation with rectal cancer. Also, evaluation of our anastomosis. If we already did surgery with anastomosis and we want to evaluate the distal anastomosis regarding the structure, regarding the recurrence of the tumor if he is in a watch and wait protocol. Again, if we did surgery and we want to determine the recurrence, rectal recurrence, it's a good for determining the rectal recurrence. In flexible sigmoidoscopy, actually, enemas is required. Rectal enema, two rectal enema is preferred prior to the procedure. Okay. The patient position is best on the left lateral decubitus position, and what else we can add? The technique actually, this technique doesn't require sedation, and actually, again, lubricating the tip of the scope and gently inserting the scope, and after we pass the sphincter complex and reach the rectum, we start with air insufflation. Of course, in our route we will find the valve of Houston and the rectosigmoid junction. Okay. We said that in the rectosigmoid junction we can use the slide by technique, but be careful, especially that these patients are not sedated, so discomfort can happen with the slide by maneuver. Again, the patient is not sedated, so air can cause discomfort due to the distension of the bowel. Okay. We said under direct visualization, we look and we can then control, after passing the sphincter, we can control the scope by direct visualization. Of the limitation that can limit our examination is the presence of stool, patient discomfort, and significant sigmoid diverticular disease. Even some diverticuli can be similar to the true lumen of the bowel, so you have to be careful, go step forward and even two step backward until you're sure that this is not a diverticuli and perforation can elect it. After you reach the maximum point you want to reach, you withdraw carefully the flexible sigmoidoscope, and you have to slowly, while you are withdrawing, to examine the mucosa. Some technique, we will discuss it in the rectum, they use the retroflex maneuver. Actually, they deflect the tip of the scope so they can sometime visualize the part of the distal rectum that is difficult to visualize when inserting, because you may bypass this part. So we will talk about the retroflex maneuver. Okay. In this procedure we can take biopsy, but biopsy we have to consider that the patient is not sedated. So for small biopsy, yes, we can take biopsy. Larger biopsy should be done during the subsequent next colonoscopy, as the patient is bowel prepared fully and sedated at least. Okay. Complication, of course, we inflate air, insufflate air, so distension can happen, discomfort, perforation. This is a rare. If we are, especially perforation can happen in the rectosigmoid junction where the rectum is fixed and between the rectum and the sacral promontory. In the rectosigmoid junction is the most common site perforation, but it is rare. You can see it's 0.002%, very rare. Bleeding can happen. It can be due to iatrogenic injury to the mucosa, or can be due to the procedure we already preform. Okay, what else we didn't add? I think we finished talking about the flexible sigmoidoscopy. Let's move down to colonoscopy. Okay, colonoscopy type of flexible endoscopic technique. Here we start talking about full bowel preparation, about some type of sedation, and actually to say that this is a well performed colonoscopy, that means we have to reach the colon at all, or the colon, the rectum, and part of the terminal ileum. Invagination of the terminal ileum is indicator of well performed colonoscopy, which is not accessible all the time. About the indication of the colonoscopy, as you see in front of you, there are many. Can be diagnostic colonoscopy, for example, in cases of bleeding that is not explained by hemorrhoid or anal condition, occult anemia, especially it can be a sign of right-sided colonic tumor, persistent diarrhea, infectious colitis, to also investigate for constipation, and to evaluate any imaging, any abnormality in the imaging, so we can proceed. This is if we are talking about diagnostic. It could be screening for polyp or cancer, or surveillance, especially after surgery, after polypectomy, if we perform polypectomy, or in patient with inflammatory bowel disease. And it could be therapeutic in a form of polypectomy, dilatation, stenting, coagulation, stopping the bleeding, by different modality. There are some absolute contraindication for the colonoscopy. Of these are the acute abdomen perforated viscous, for example, or toxic megacolon. Of the relative contraindication, as you see in front of you, severe cardiopulmonary disease, severe bleeding tendency, acute diverticulitis, pregnancy, recent MIPE, and unprepared bowel. There are many pathology can be seen, not only these which is described here, but of these are diverticular disease, polyps, polyposis syndrome, malignant tumor, submucosal tumor, inflammatory bowel disease, vascular malformation, solitary rectal ulcer, melanosis coli, and biles. Okay. We said if we start talking about colonoscopy, so we should mention the bowel preparation regimen. Okay. If you start talking about bowel preparation, which is crucial part of the colonoscopy, we said in flexible sigmoidoscopy, it's enough to do rectal enemas, but in flexible colonoscopy, we need bowel preparation. Actually, bowel preparation is usually described as the most difficult or unpleasant part of the exam by the patient. So some patients cannot tolerate the bowel preparation, and about quarter of the patient in the United States are not well prepared. This is a very high percentage. Of course, not well prepared due to many causes we will see in the next few minutes. We have many type of bowel preparations, and the selection of each type depends on actually three factors. First, it is the sometime practitioner or the endoscopist preference. He used to learn or remember 2 to 3 regimen that he is familiar with or sure with the quality of the preparation after using it. And other factor is the patient condition. So we will see in the next few minutes that some type of bowel preparation is relatively contraindicated in some patients. And third cause or third factor that may affect the selection of bowel preparation is the insurance coverage and of course the lower cost of the preparation. As you see here, it could be classified to 3 or 4 type of bowel or categories of bowel preparation. These are the isoosmotic. Of them, the most popular is the polyethylene glycol. It's worth to remember it. Polyethylene glycol or PEG. And we have hypoosmolar, we have hyperosmolar. When we talk about hyperosmolar, we talk about the electrolyte solutions such as sodium sulfate, sodium nitrate, magnesium citrate. These are the hyperosmolar preparation, and some stimulant preparation. This used as adjunct with other agents such as Senap, Escadil, Dilcolax, and you can see here how many agents we can use to to prepare the bowel. Actually, we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So there are many. But just to rapidly review these agent, one of the most important is the polyethylene glycol. The polyethylene glycol actually it's not secreted nor absorbed, so it's will be evacuated all. And what else we can add about polyethylene glycol? Usually the polyethylene glycol is combined with electrolyte solution to be isoosmotic or slightly hyperosmotic, and this is the polyethylene glycol electrolyte lavage solution. This means that it is polyethylene glycol with some electrolyte solution. This is the gold standard, most popular to use. Okay, it's called, this is the polyethylene glycol ELS or electrolyte free solution, Golatili. I don't know, I'm not sure about the pronouncement, but let's talk about a little bit about advantage and disadvantage. We say polyethylene glycol electrolyte lavage solution. That means we have polyethylene glycol and we have sodium sulfate, sodium bicarbonate, sodium chloride, and potassium chloride. The volume, imagine that the patient should drink 4 liters, so it's large volume. Dosing, actually we will see in the next few minutes that we split, we divide this 4 liters to 2 or 3, mainly 2 dose, so it is proven efficacy regarding the quality of the bowel preparation and regarding the patient tolerance. So we can take these 4 liters, 2 liters the day before the procedure and 2 liters at the day of the procedure. Of the comments, polyethylene glycol electrolyte lavage solution have poor taste, so it's not toleratable well. Large volume should be drank, and these are of the disadvantage, let's say. Okay, polyethylene glycol, we have another formula is the sulfate free. Actually, they remove from the polyethylene glycol electrolyte lavage solution the sulfate, so we have the sulfate free. The advantage over the classic polyethylene glycol electrolyte lavage solution that it is more tolerable, it's bitter taste and smell. You can see the composition is the same, but with no phosphate. With no sulfate, sorry, with no sulfate. Amount, it's 4 liter. Dosage the same, split dose, first dose and second dose. This is the sulfate-free formula of polyethylene glycol electrolyte Laval solution. We have we said 4 liter. We have the 2 liter only. We bowl prep by 2 liter of polyethylene glycol electrolyte Laval solution, and actually it's nowadays proven that the efficacy of bowl preparation is the same when we compare it to 4 liter. The low volume, we call it the low volume 2 liter polyethylene glycol electrolyte Laval solution combined with ascorbic acid. But actually the low volume is, as you see here, is misleading actually, because in addition to the 2 liter he should drink 1 liter, so 3 liter in total. But it's better than 4 liter. This is the low volume polyethylene glycol electrolyte Laval solution with ascorbic acid called the movie prep. So the composition, it is polyethylene glycol, sodium sulfate, sodium chloride, ascorbic acid, 2 liter plus 1 liter of clear fluid, splitted dose. The disadvantage of this low volume is the poor taste. I don't know if the noise in the background is clear, but for me, okay, poor taste, and it's expensive. Okay, of course, any agent that contains phosphate is contraindicated in patients with G6PD, glucose 6-phosphate dehydrogenase deficiency. Okay, I think I have to speak louder in order that the noise is not disturbing us. We talked about another agent that is also accommodated to use a low volume is what we call the Miralax. It is polyethylene glycol but mixed with sports drink. Unfortunately, this is not FDA approved and usually combined with laxative. Sport drink, it's just for mixing the polyethylene glycol. And so what else we can talk about? If we want to talk about the polyethylene glycol plus sport drink, here it is. It is polyethylene glycol plus sport drink, 2 liter, split dosage, the same, well tolerated, not FDA approved. Okay, this is the sport drink. Till now we are talking about the isoosmolar agent. What else we have? We move to the hyperosmolar agent. The hyperosmolar agent, these are the electrolyte associated, such as magnesium citrate, sodium sulfate, sodium phosphate, etc. Okay, if we are talking about magnesium, actually most of the hyperosmotic agents are relatively contraindicated or used with cautious in patients who are elderly, in patients who have G6PD, in patients who have renal function disease, so be careful. This is the magnesium citrate, not FDA approved, and unfortunately toxicity, especially in elderly and those with kidney disease. This is the oral sodium sulfate. Oral sodium sulfate, similar in efficacy to the low volume polyethylene glycol, and better than the 4 liter polyethylene glycol. The oral sodium sulfate. Major advantage of oral sodium sulfate that it has no significant fluid or electrolyte shift. Phosphate, sodium phosphate, you can see here that sodium phosphate, we have two form, I think, yes. We have two formulas. We have the aqueous formula, this one, which is associated with many electrolyte disturbances and acute renal failure, so it's withdrawn from the market. The tablet formulation of sodium phosphate, okay, it's bitter, but you can imagine that the patient should take 32 tablet with 2 liter. Okay, this is the sodium phosphate. Sodium phosphate called Osmoprep. Okay, what else we have? Sodium phosphate. We talked about the sodium phosphate. Sodium phosphate, also one of the disadvantages of sodium phosphate, that it can cause mucosal inflammation and ulceration that can mimic the inflammatory bowel disease. So its uses in patients with inflammatory bowel disease is restricted or contraindicated. So sodium picosulfate, as you see, combined with magnesium citrate, recently become popular. We will talk about it. This is low volume bowel prep. This is the Prepopic. Here it is. Type of hyperosmolar agent. Here it is. Sodium picosulfate. Less volume, well tolerated, expensive, avoiding patient with renal insufficiency. Okay. So we said we have isoosmotic, hyperosmotic agent. We reviewed them rapidly. This is a nice algorithm for selecting patient with the optimal bowel preparation, and you can see the first step. Are there any contraindication to bowel preparation, such as do we have intestinal obstruction, peritonitis, perforation, toxic megacolon? Yes, cancel the procedure and think of an alternative. Okay, no, we have no contraindication. Is the patient at risk for electrolyte or fluid imbalance? No. So the patient, if he have no risk of electrolyte or fluid imbalance, he can take the polyethylene glycol plus the sodium phosphate, or the sodium phosphate. He can take sodium phosphate or polyethylene glycol. If he have problem with electrolyte or fluid imbalance, so we avoid sodium phosphate and we offer only polyethylene glycol. And if he have fluid imbalance, low volume polyethylene glycol is sufficient. Third question, is the patient concerned about tolerating full volume? Okay, if he cannot tolerate the 4 liter of polyethylene glycol, if there is no problem, so please recommend the 4 liter polyethylene glycol, especially in patients who worry about the cost or insurance coverage, because the low volume is more expensive and has a history of poor bowel preparation. If the patient have concern about the full volume polyethylene, full volume means 4 liter, so we can offer the low volume polyethylene glycol, especially if the patient at risk of electrolyte and fluid imbalance. We can offer sodium phosphate or low volume polyethylene glycol if there is no risk. I hope it's clear. So question 1, any contraindication to bowel prep? Question 2, any risk of electrolyte or fluid imbalance? Question 3, is there a problem in using full volume polyethylene glycol? This is, we talked about the regimen. How the bowel preparation doesn't depend on the agent we already discussed. There are other adjunct to the bowel preparation. You can see here that, for example, this table explain what the patient should do 1 or 2 days before bowel preparation. You can see here that it depends. Do we have morning colonoscopy at 8, 9 o'clock, or late colonoscopy at, for example, 1 a.m. to p.m. 2 p.m. So it depends. Let's take as a standard the morning colonoscopy. So last solid food should be the breakfast day before, and he should start clear fluid, no solid food, when he stop the breakfast of solid at the day before 8 a.m. day before the surgery, the colonoscopy. And he should start day before the surgery with the bowel preparation agent. This is the Pico Prep. I will show you what does it contain. It actually separated not to 2 doses but to 3 doses. First dose Pico Prep at 2 p.m., second dose 4 p.m., third dose 6 p.m. Okay. Okay, this is also nothing to add here. This is an instruction from the hospital where I work. I can just translate it to you. The day before the day of colonoscopy, do not eat any type of food, just drink liquid with large amount of liquid as tolerated with apple juice or 7-Up or water. Take Delcolax tab before the use of the Pico Prep and after 5 tablets before the Pico Prep. Delcolax is the Biscodil. 5 tablets before the Pico Prep and 5 tablets before the Pico Prep. So if we split it to 3 doses, he need 30 tablets. Use Pico Prep 3 parts. Actually, each part of the Pico Prep, I don't know what we call it this. This is the Pico Prep sachet. So each one should be diluted with 150 cc of water and split it to 3 doses. The first dose at 9 o'clock before the day before the colonoscopy. The second dose 3 p.m. the day before the colonoscopy, and the last dose at 7 o'clock p.m. plus plenty of water, about 4 liters of water at the day of the colonoscopy. Please bring person relative to you to help you. Take a warm shower. This will relax the muscle. Do not eat vegetables or fruits with seeds such as watermelon, popcorn, even 3 days before the procedure. And do not drink the juice that have stain or can stain in the bowel lumen, such as Java juice, mango juice, strawberry juice, orange juice should be avoided. Okay, and this is the same regimen. The regimen differ from one institute to the another. Okay, this is again another regimen: bowel preparation low residual diet 2 days before the procedure, clear fluid at the day of the procedure, polyethylene glycol, they took the low volume 2 liter over 2 hour, and it be adjust the dosage if the patient have a chronic constipation, inflammatory bowel disease, or left-sided obstructive lesion. This is the Dilcolax. This is a Pisco deal, which we talk about, and this is the Pico Prep. We are familiar with the Pico Prep because this is what we use in our hospital. So you can see the Pico Prep contain sodium sulfate, magnesium magnesium oxide, citric acid, and this is the Pico Prep. So what these are called sachets? I don't know. These are 3 packs. Okay, this is the Patson Pauli preparation. Is after colonoscopy, the endoscopist used to document the level of Pauli preparation according to Patson Pauli preparation. It's a score from 3 to 0 or from 0 to 3. You can 3 is clear, entire mucosa is seen, to minimal residual, most of the mucosa is seen, and 1 residual stool and liquid, part of the mucosa. 0, the mucosa is not seen and the stool is present. And actually here they put the numbers 1, 2, 3 according to the site, left column, transverse column, right column, and the summary will give us the more high, the best bowel preparation. Okay, I know that the part of bowel preparation is a little bit difficult, and what we use is we are familiar with 1 to 2, 3 regimen of the bowel preparation. This make the challenge with bowel preparation to remember more easy. Let's talk about some special consideration of them, the poor or difficult bowel preparation, what we should do, what to do. Okay, and special consideration, we are going not only to discuss poor difficult preparation, but also we will talk how to deal with patient on anticoagulation. How do we need antibiotic or routine antibiotic? Do we need how to deal with sedation? So we will review these topics in rapid. We said previously that about quarter of the patients in the United States who underwent colonoscopy are poorly prepared, and actually there are 2 main reasons for, or 2 main risk factors for poor preparation. This is the previously poor bowel preparation due to, for example, patient intolerance or for chronic constipation. And we said that intestinal obstruction is contraindicated. We are talking here about chronic constipation, functional constipation, that may be, for example, in patients with irritable bowel syndrome. So, again, some information about the bowel preparation. We said that the split dose is proven that it is better than the 1 dose, to take it 1 time. Split dose, you can split it to 2, 3 doses and take it. It's not clear or not proven that taking clear liquid is better than taking low residual diet. So it's not proven. The proven is the split dose. As you see here, the low quality bowel prep is defined as the bowel prep that have no ability to detect any lesion less than ½ centimeter or 5 millimeter, and this will reflect negatively on the frequency of repeated colonoscopy. Okay, so what we do if we have patients who have, for example, chronic constipation? We can start, we said that classically we start bowel preparation day before the colonoscopy, but we can extend this interval to 2 days before the procedure and even more. and even more than 2 days. Okay, what other measurements? We can add more osmotic agent. Add more osmotic agent to the patient, of course, with cautions. What else we can do? Many patients will have a kind of intestinal motility disorder, gastroparesis, so antiemetic may be helpful. Or finally, we can admit the patient and give this agent through a nasogastric tube or rectal tube. There are some agents that are tailored to the patient who have, for example, constipation. You can see this is pre-piquet type of osmotic agent used for bowel prep, and C is I think this means constipation. So these are directed to the patient with constipation. You can see these are two regimens used in different institute, in different hospital, and these are designed to deal with patient with constipation. And you can see that these are the instruction to the patient to start 7 days before the procedures. Of these instructions is, for example, to stop iron 5 days before the procedure. If you are taking aspirin, so no problem. Do not smoke all kind of smoking, tobacco, cigarette, marijuana, so you have to stop. And the here advice or depend on the osmotic agent, the Miralax, which we discussed previously, but they start early, about 5 days before the procedure, with a drink called Gatorade. Actually, in my country, I haven't this, or I didn't see this. This is a type of energy drink. So they started about 5 days before the procedure, and they give you what you can drink, what you shouldn't drink, and etc. Here is another regimen. You can see here that they actually, nice picture here, clear liquid diet detail. For example, what you can and what you should avoid. Let's see what you should avoid. You should avoid milk. You should avoid dairy product, creamer, no juice with pulp, no red or purple juice, no food pieces. You can brush your teeth, but do not swallow that. Okay, so okay, let's move to the, do we need antibiotic for routine colonoscopy? And the answer is no. For routine, for prophylaxis, antibiotic is not indicated, and this is logic. We just review the instruction for patient before colonoscopy, and no one advise or mention the use of antibiotic. We do not need antibiotic in cases of, for example, to prevent infective endocarditis, for prophylaxis against infective endocarditis. We do not need antibiotic for vascular grafts. We do not need antibiotic for orthopedic prosthesis. We do not need antibiotic for non-valvular cardiovascular device. But we need antibiotic in cases of high-risk cardiac condition, such as valve replacement, and also in cases of GI tract infection, especially if the agent is enterococci, so spillage can occur and antibiotic is recommended. One case in which clear indication for antibiotic is clear is those patients who have continuous ambulatory peritoneal dialysis. In order not to disturb you, I bring a picture for patient with continuous ambulatory peritoneal dialysis. Yes, it's recommended to use antibiotic based on low level evidence, but it's recommended. What antibiotic to give if we are going to give antibiotics? So it's recommended to give ampicillin 1 gram plus single dose aminoglycoside with or without flagyl or metronidazole. Okay. Anticoagulation. Anticoagulated patient. Okay. And the decision to proceed with anticoagulation and colonoscopy, or to withhold the anticoagulation, or to delay the colonoscopy is difficult and should be discussed with the doctor or the physician who is managing the anticoagulation. So hematological consult may be needed. And actually, you have to do a balance between the risk of a bleeding that can happen if we continue an anticoagulation and the risk of thromboembolic event if we stop the anticoagulation. And this is actually a difficult, not that easy. And if we are talking about screening colonoscopy with biopsy, this is usually a low risk procedure. But if we are proceeding to polypectomy, so this is a high risk procedure. But the problem that this information is not useful. Why? Because we do not expect we do not know the need for polypectomy in advance. We actually determine this in the procedure. Okay. The general recommendation by the ACG recommendation is to hold, to delay, postpone the procedure until no longer we need the anticoagulation if this can be happened. But we know that some patients can take long time on anticoagulation. One of the important information that if the patient is using aspirin or non-steroidal anti-inflammatory drug, so it's not suggested, it's not recommended to stop this agent. We can proceed, especially in patient with on dual anticoagulation agent. So aspirin can be continued. If we want to stop aspirin, especially in patient with high risk, so we know that we have to stop it 7 days before. Clopidogrel, Plavix should be stopped also 5 to 7 days before. If we are talking about warfarin should be stopped 5 days before, and we should start low molecular weight heparin, and we should stop we start low molecular heparin 5 days before the procedure until 12 days before the procedure we stop it. And actually some vascular surgeons prefer warfarin because it's reversible, while or we have antidote to warfarin, while low molecular weight heparin doesn't have antidote. But this is called the bridging therapy, and there are studies that actually doesn't support the bridging therapy. This says you can stop warfarin without bridging, proceed. But I think bridging is the classic teaching information that we should use with warfarin. The direct thrombin inhibitor and factor XA inhibitor, if you want to know what I'm talking about, this agent, Pradaxa, Dabigatran, and Xalerto, Eliquis, etc. These agents should be stopped 1 to 5 days depending on the agent. This is why I said in the beginning that we need consultation from our senior medical colleague. As we said, bridging sometimes is not advisable, but it's not our. Okay, let's move to sedation. Okay, sedation, I can say it's preferable when performing colonoscopy. Why it's not mandatory? Because I know that some colonoscopic procedure, which is not ideal, that some colonoscopic procedure is done without sedation, but the ideal, preferable to do under sedation. And actually we have different type of sedation. As you see, the most commonly used is the conscious sedation or mild or moderate sedation, in which we do not need the anesthesiologist. It is an endoscopist directed anesthesia. In this regimen, we use benzodiazepines such as midazolam and opioid such as fentanyl. And of course, we need IV access, we need nasal monitoring, we need pulse oximeter, ECG monitoring. These are required. Okay. If we move up in the anesthesia level, so we are talking about the deep sedation or monitored anesthesia care. Here we start to talk about propofol, and many talk about, do we need the anesthesiologist to be with us while performing the colonoscopy or not? It's preferable, we will see in the next few minutes. So deep means that we start to use propofol, and general anesthesia means definitive endotracheal intubation or securing the airway, and this is the third step in our sedation. Okay. Of course, sedation have multiple reasons. It's better patient and doctor experience, and also it gives us better outcome. Okay, the most commonly used is what we call the endoscopist directed moderate anesthesia, in which we use, as we said, benzodiazepine and opiate. Okay. If we are talking about the use of propofol or the other type of the deep sedation, the use of propofol, we start to talk about deep sedation, and we start to ask ourselves, do we need the anesthesiologist? Because here we will start to talk about respiratory depression, and at some point we may need endotracheal intubation. As we said, the most commonly used is the endoscopist directed moderate anesthesia, in which we use just benzodiazepine and opiate. Please be careful that the antidote is present, such as naloxone for opiate and flumazenil for benzodiazepine. If we want to compare between endoscopist directed moderate anesthesia, in which we use only midazolam and opiate, and we may use buscopan, so this is a longer to achieve. When we want to compare it with more deep sedation with propofol, this is longer to achieve. The recall intra procedure is present, poor intra-procedure sedation, prolonged recovery, and post-procedure emesis. Of course, we know that propofol have antiemetic advantage. Okay. As we said, propofol provide deep anesthesia, sedation, amnesia, hypnosis. There is a study that, I don't want to say support or not against the use of propofol by the endoscopist or the assistant of the endoscopist, assistant of the endoscopist. You can see here the safety of non-anesthesia provider administered propofol sedation for advanced endoscopic procedure. But this will add more responsibility to the endoscopist, and his job is to investigate the colon, not investigate the sedation of the patient. Of course, The propofol have advantage in which it provide more deep sedation, better satisfaction of the patient and the doctor, and better recovery after the procedure. Okay, there are some alternative or adjunct, I can say, for the sedation. You can see here we have the patient controlled sedation, in which he is actually holding instrument and he press when he feel pain, and a programmed already instrument deliver painkiller for the patient. One of the nice picture I find while actually searching about this issue, so I found that the use of virtual reality exists while performing the colonoscopy, so the patient may watch his preferable film while or best film while he's going to proceed with colonoscopy. The instrumentation, we are going to talk about a nice part of this lecture. So, and how the colonoscopy looks like, you can see this is the colonoscopy, and actually the length depend on the manufacturer. It can range from 1 meter 33 centimeter to 1 meter 70 centimeter. Okay, the outer diameter also differ. Here you can see adult colonoscope from 12.8 to 13.2 millimeter, smaller pediatric 11.6 to 11.7, and even neonatal we have 9.7 to 9.8. You can see here adult, pediatric, and this is the outer actually diameter. If we want to talk about the part of the colonoscope, I don't know why I love this part of the lecture. You can see that this is the control. This is, if we do zoom in here, we will see this part, and you can see here that we have two wheels. We already talked about these wheels and the benefit. They control the deflection of the distal part of the scope, the tip of the scope, up, down, right, left. So up, down by the big wheel, right, left by the smaller control. And you can see here we have the water and air insufflation button, and we have here the suction button. We have actually, this is a fixation lever just to fix the wheel in order to manage to use other buttons, so we fix the knob at one direction. What also important to know here is the working channel. You can see here in this part, it was clear when we talk about the sigmoidoscopy. Here, over here, what we call it the instrument channel, in which we insert the wire, the snare, the forceps to do polypectomy. This part, if you see here, this is called the stiffness part, in which if we rotate it right or left, we will decrease or increase the stiffness of the colonoscopy. I think we have a picture here. You can see this is the stiffness tube, and we can actually control the stiffness. This is a nice idea actually. Okay, what else we have to see here? Okay, fixation, just the fix, water, suction, nice one. Okay, this is how it looks like. If we look over here, this is what we see. We see, you can see this is a light source actually, and here we have the fibers, and here we have the light itself, the lens itself. This is the lens. This is the light, this is the lens, this is from where the water come, this is the air and water also, you can see here, and this is the biopsy channel. We said that we insert the instrument here, we insert our wire here, it will comes from here at around, they described at 5 o'clock position. I don't know, this is a 5 o'clock, yes, maybe if it will be down, it will be at the level of 5 o'clock. Of course, there are different, this is the basic, there are different type. For example, some endoscope have a two working channel. This is working channel number 1, working channel number 2 for more advanced therapeutic procedure. This is the stiffness tube which we talk about. Actually, the scope itself this is active. You can see active bending. We control it by the wheel. This is passive bending, and this is passive bending, and this part we control the stiffness by the wheel over here. Okay, how to perform? We reviewed how does the colonoscope look like. Now how to perform the colonoscopy. Okay, colonoscopy technique, and as we mentioned previously, that colonoscopy is a procedure that you will gain experience by practicing. Okay, theory will help us, but practice is the way how to gain experience. Of course, not all procedure are easy to perform. We should keep in mind that we have redundant tortuous colon. We should keep in mind that some angulation can face us, especially post in patient who have operation or inflammatory process and causes adhesion. The change of the anatomy, especially after surgery, make the colonoscopy difficult even with experienced endoscopy. Okay. Before proceeding to the colonoscopy, we should gain consent. And consent should be gained for the procedure itself and for the anesthesia. We need separate consent for the anesthesia. Of course, we have to remember that we should put the patient on monitoring. This includes ECG, pulse oximeter, the heart rate, etc. And the patient is best, as you can see in the picture in front of you, put in the left lateral position. Okay. After we provided anesthesia and reach appropriate level of anesthesia, we start by visualization. As we said at the beginning of this lecture, visual inspection of the anal margin and anal verge, and we should proceed to digital rectal exam. For this reason, we may doubly gloved our hand in order to perform the digital rectal exam, remove it, of course, with lubrication. Okay, and after that we insert our the tip of the colonoscope by our right hand. It should be lubricated, the index finger usually with the tip of the colonoscope should be lubricated well, and when we reach the rectum we start to insufflate the air. As you see here, that the rectum, first of all, examination of the anal region, the rectum, digital rectal exam. Please lubricate the scope, and you can use your finger, as you see here in this picture, your finger to insert the scope, because we know this, the last part of the scope is redundant, so finger guided insertion of the colonoscopy. And you see here upper rectum on the way in, lower rectum on the way out. What they mean that when you insert the scope, you actually bypass a segment of the rectum and anus that is not examined by the tip of the colonoscope. So this can be examined when I go out by what we call it the retroflex view. I pent when I withdraw the colonoscope, pinting the colonoscope, and we can examine the lower part of the rectum. This is what we mean by lower rectum is in the way out. The lower rectum, we cannot actually examine it by the colonoscope at the beginning of the procedure. Okay, of course, the rectum can be, after bowel preparation, can be full of liquid stool, so it's better to suction this stool, this liquid stool, because while performing the colonoscopy, the patient can cough due to the irritation of the respiratory system when inflating air, for example, and expulsive diarrhea can happen. So it's better to actually suction. You have to remember that the suction part is located at the 5 o'clock, so the scope should be at the air fluid level, so that the suction is in the water and the scope you can see the lumen. Also, the suctioning, we said, if you remember, the suction bottom is a gradual bottom, so you can control the force of suction, and it's recommended to use low suction and repeated suction, because if you use very high suction, the mucosa will stuck to the scope, and what we call it the red view will be, you will see the mucosa only. So repeated suction for short period is what recommended when talking about suctioning. In our first distant in the colonoscope, we will see the valve of Houston and the rectosigmoid junction, which is one of the hardest part to bypass. Okay, what else you can see here? Endoscopic appearance of the rectum. This is the valve of Houston. 1, 2, 3. Here we are just in the rectum, a little bit up the rectosigmoid junction, which is one of the first difficulty that can face us. Okay, as we reach the sigmoid, actually you can see here, this is the sigmoid, one of the parts that hard to insert the scope in. It's advisable to use a clockwise torque, and okay, you can see, do you see the black shadow here? Sometimes it guides us that this is the true lumen where we should go. Okay, we usually try to keep the scope straight, and sometimes it's advisable to use repeated advancement and withdrawal. As you see here, combination of a short advancement and withdrawal with clockwise torque may be helpful. And in some literature they say go 2 step in or go 1 step in, 2 step out. This means that be careful. Push and pull back technique called. Okay, we talked about the slide by technique, and we say please, slide by technique, try to avoid it. If you want to perform it, this is in the presence of an experienced endoscopist. The slide by technique, as we said, it is blindly pushing a pinted tip of the scope or deflected tip of the scope to the wall. So the wall of the sigmoid will guide you, but try to avoid it because of the risk of perforation. Okay, loop is a common, especially in the sigmoid. We know that the sigmoid is redundant, the most redundant part of the colon, and not only that, there are multiple, most likely to have diverticulosis, and as we will see, diverticulosis, some diverticuli will mimic the true lumen of the, will be large, that they mimic the true lumen of the colon, and also it's a higher muscular tone. This is what we mean by looping. You can see here, when you push your scope, the sigmoid is redundant, and this is the N-shaped loop. This is the alpha shape loop. When to suspect the loop? If I am inserting my colonoscope, but the tip is not moving by this distance that I push in, called the one-to-one progression, or I have discomfort or stiffness of the wheel when moving the tip right, left, up, down, or when there is paradoxical movement of the scope, so we can suspect the N loop and the alpha loop. Okay, we said we commonly in the sigmoid use the technique we previously discussed, the torque, clockwise torque. It's like this to increase the stiffness, and also the insertion pull back technique, insert and pull back rapidly, jiggling or dithering. So this will help the sigmoid to accordion, to shorten over the scope, so it will be easier to. One of the technique, if I'm suspecting a loop in the colon, I can push, called the push through the loop, pushing through the loop technique, because when the scope reach the descending colon, by some technique the loop can be reduced. So pushing through the loop is a recognized method, but you should notice that there are no pain or no resistance or minimal resistance and acceptable discomfort. Let's say you can see here the diverticuli in the sigmoid. This is a small one, but it can be large, that it can mimic the true lumen. One of the way, as I said, to follow the true lumen is to follow the shadow, the dark zone. Okay, what else I want to also, when we reach the descending, the first thing we should do, if we suspect any loop, it should be reduced. Navigating, traveling through the descending is easier than the sigmoid. The descending is a straight with less muscular tone, so we said reduce the loop and we move until we reach the splenic flexure by simple maneuvers, torque and simple deflection of the tip. Okay. What else I want to add about the descending before talking about the splenic flexure? This is the descending. It's a straight oval in shape. You can face a fluid here and suction it. We said the suction technique is short repeated suction with low force, because if you suction very fast, the mucosa can stuck to the scope. You can see at the last part of the last colonic part of the descending the splenic flexure, and you can see the shadow of the spleen. You can see here, this is the shadow of the spleen, this is the spleen, if you see. So this is one way to ensure that we reach the splenic flexure. Okay, and as we said, when we reach the splenic flexure, we start to notice the bluish discoloration of the spleen. If there is a fluid, please suction it. It's reached around 40 centimeter from the anal verge if there is no looping. Sometime we may use adjunct to pass the splenic flexure. Of these adjunctive maneuvers is the changing of the position. You can see the classic left lateral position in which the patient started. You can see here we have two flexure. When we change the patient to the right lateral position, actually it make it easier to pass. This is one of the maneuver. Other maneuver is abdominal pressure. We will discuss them in the next few minutes. Transverse colon, the classic shape of the transverse colon is, you see, the triangular shape. So triangular lumen and haustration, and actually it is completed by reaching the hepatic flexure. We can use adjunct to travel through the transverse colon, such as changing the position and external pressure and suctioning of the fluid. You can see here that loop can be formed in the transverse colon. Of this loop is the gamma loop. You see, especially after pelvic surgery, the mid-transverse can be fixed downward. So this is the gamma loop. How we can get rid of this loop is by central upward abdominal pressure, and this is the gamma loop. Okay, this is the abdominal pressure. Suprapubic pressure, this is for the sigmoid loop, the N loop and alpha loop, and upper abdominal pressure upward to the transverse colon, and the right loin pressure for descending. This is not extremely, the most important are these will help us. Okay, as we said, the transverse colon is completed when we see the hepatic flexure, when we reach the hepatic flexure, and the hepatic flexure is confirmed by the bluish discoloration, as you see here, the bluish discoloration of the liver. Okay, we reach the hepatic flexure and the ascending colon. We said the hepatic flexure, we can see the liver, the discoloration of the liver. It's noticed that the ascending colon is wider lumen with thin lumen. Actually, this is a thin wall, let's say. Changing position and pressure and suctioning will help. Okay, how suction will help? Actually, when you do intermittent suction, actually the scope will go more in the down in the ascending colon, and the colon will bring, and accordion of the colon will happen. Okay, the patient can be put in supine position when navigating the ascending colon. This will help with the use of abdominal pressure. Okay, of course, if we have loop encountered during the transverse colon, it should be reduced once we reach the ascending colon. Okay, as we said, the intermittent suction will draw the tip of the scope down to the cecum. So what else? We reach the cecum, and there are three distinct features of the cecum. First is the ileocecal valve. You see it over here. The ileocecal valve is actually a lipomatous, a fold of fat and yellowish discoloration. The valve itself usually hidden, but you can see the fat over here, the yellowish discoloration here is seen. The cecum itself has the crow foot appearance, the Y shape here. Okay, and the appendiceal opening over here. Okay. The ileocecal valve actually is a mark between the ascending colon and the cecum. Okay, again, here the valve, the ileocecal valve is actually varied endoscopic appearance. It's variable appearance actually. Here you can see the location of the ileocecal valve. Here, I don't know, I think behind this fold, a lipomatous fat accumulation. Between them you will find the ileocecal valve. Here is just, they show you that this is the crowfoot appearance. You see the ileocecal valve over here. This is definitely the ileocecal valve because it's a thickened yellow fat and the valve is hidden between them. Okay. Another maneuver that can help us to determine the ileocecal valve is the presence of gas bubbles. These are the enteric continent of the small bowel, so we can follow the gas bubbles that come from the small bowel. Okay, if we want to say that we have complete colonoscopic exam, we should reach the cecum completely. Again, what is this? This is endoscopic appearance of the appendiceal orifice. This is the appendix, this is the crowfoot, and this is a lipomatous fold in which we have the ileocecal valve. Okay. To ensure that we did a complete colonoscopy, we should photo document our procedure. This is to ensure quality of complete exam. Transillumination can be used, but it is not reliable indicator for complete colonoscopy or reaching the ascending and the cecum. Okay. What else? Intubating the ileocecal valve. If we determine the ileocecal valve, we can enter the ileocecal valve, and this is actually not always mandatory, but for example, in patients with inflammatory bowel disease, we know that in Crohn's disease, the terminal ileum is the most affected part. So it's important part of the colonoscopy to enter the ileum in case of inflammatory bowel disease. Other scenario is lower GI bleeding. We know that we have an entity called obscure bleeding, in which the colon have no lesion that explain the bleeding, so the bleeding can be from the small bowel, called obscure bleeding, and the blood will be accumulated in the terminal ileum. Just identification that there is a blood in the terminal ileum means that we are dealing with small bowel bleeding, which is harder to deal with. Okay, what else? Um, the success rate of intubation, actually, you can see here that routine ileal intubation in one study was tried and noticed and found to be successful in 90%, which is good. The need for intubation, for terminal ileal intubation, to say that I complete my colonoscopy is not mandatory, or let's say it's controversial, because the gross endoscopic abnormality is 1%. So, and it's not mandatory to routinely intubate the ileum. We said we have certain scenario, two scenario, inflammatory bowel disease and lower GI bleeding, that we may need to intubate the colon, the ileum or the ileocecal valve. What differ the ileum? When we enter the ileum, it looks like a granular. You see here the granular appearing mucosa, small, sorry, small red dot all over, with also the lymphoid aggregation, which can simple even polyps. Okay, you can see here multiple lymphoid follicles that may simple small polyp. What else I can add when we want to go back or withdraw the colonoscope? It's important to look behind the fold that we didn't see. We have cecal fold, behind them maybe lesion that is hidden. We can use the retroflex. We can deflect the tip, bind the clip, so we can see the lesion behind the folds. Biopsy can be taken if it's indicated, of course. Okay, what else? What else we didn't say about Kirsten? Okay, let's move about how to withdraw the or remove the colonoscope. Okay, withdraw time is the time needed to remove the colonoscope from the bowel, and actually it's used as a quality measure for colonoscope, and it has its drawback, its disadvantage when we use it as a quality. We will discuss it in the next few seconds. Actually, you can see in the withdrawal of the colonoscope, we can use the retroflex, actually the bending of the colonoscope, and seeing the proximal tissue we already passed, especially in the rectum. If you remember, we said that the lower rectum, actually we pass it when we insert the colonoscope, so we can use the retroflex. Yes, many studies said that it's not proven that the retroflex maneuver can increase the detection of any lesion, but why not to use it? It has its disadvantage. It may cause mucosal injury and discomfort to the patient. The classic time to withdraw the colonoscope is 6 minutes up to 9 minutes. Please slow and steady, in order to, while you are withdrawing, also navigate any lesion, and the retroflex for the lower rectum. Okay, what else in the withdrawal? That's what we said. Alternative technique, we can use instead of air insufflation, we can use the carbon dioxide. The advantage of carbon dioxide is that it is rapidly absorbable in the bowel and excreted through the or expelled through the respiratory system, and this gives a several advantage: less pain, less pain and bowel distension and discomfort. Also, if we are planning for combined surgery, for example, endoscope and laparoscope, again, if we are planning to use, sorry, I have been disrupted. If we want to combine laparoscopic and endoscopic approach or colonoscopy, so it's preferable to use the carbon dioxide. This is because less bowel distension will happen, and this will facilitate our work with laparoscopy, especially if the ileocecal valve is incompetent. If it's incompetent, so with inflation, the small bowel will get larger, and this will make our laparoscopic job more harder. Okay, other technique we can use is water insufflation. And instead of using air insufflation, we use water to distend the bowel. It has many advantages in that it's proven. You can see here we put actually the colon full of blood and we navigate. It has many advantages. Of them, it is less pain, less sorry, looping of the scope, and more stabilization of the colonic wall. The colon wall will be more stable, but it is associated with higher rate of incomplete colonoscopy and unfortunately higher rate of missed adenoma detection. So it has advantages and disadvantages. Chromoendoscopy. Okay, chromoendoscopy, it's using a dye to inject through the colonoscope, usually in digocrine, by a spray catheter to coat the mucosa. This will help us in distinguishing the dysplasia and the glandular structure and the pit pattern. The pit pattern, these are in the top of the polyp, whatever malignant or benign, there is a slit. The shape of the slit is called the pit pattern, can be like stars. Actually, it have a classification we will talk about when we talk about the endoluminal surgery, the pit pattern. So it's proven that chromoendoscopy is useful in patient with inflammatory bowel disease because the lesion, the malignant lesion in inflammatory bowel disease is usually flat, so it enhances the detection. This is the chromoendoscopy. Narrowband imaging, simple principle. It actually uses green and blue color or wavelength and eliminate the red wavelength. So it's useful in detecting lesions that are superficial mucosal structure, especially the microcapillaries. Actually, we will see, you will understand the concept of narrowband imaging. It depends on the vascularity of the lesion. For example, the adenoma actually have an increased vascularity, and so it will look like a brown lesion on a blue-green background. To show you, this is adenoma. If you see, look here, it's a brown when we compare it to the blue and green background. So this is adenoma classified according to its color and vascularity. Do you see this slit? These are the pit pattern actually. Okay, what else we have? The serrated polyp. This adenoma and serrated polyp have malignant potential. The serrated polyp are hypovascular and they appear pale against the against the normal background, which should appear blue and green. Okay, it is documented or it's proven that it results in higher adenoma detection rate when we compare it to the conventional or standard normal white light endoscopy. If we want to compare it, if we want to talk about inflammatory bowel disease, so chromoendoscopy and narrowband imaging is the same effect. You can see here, this is the narrowband imaging. They classify it to 3 types according to the how does they look after narrowband. The type 1 is the hyperplastic, and you can see that the hyperplastic actually is green and blue compared to the background, so there is no difference. It is same or lighter to the background. This is hyperplastic polyp, whereas adenoma, it's more brown, and this is due to the high vascularity. And deep submucosal invasive cancer, it looks darker, if you see. So this is due to the lack of vascularity, brown or darker. Okay, full spectrum endoscopy. Full spectrum endoscopy, as you see, it's the use of coupled lens. As you see in this picture, we have additional coupled lens on each side of the colonoscope to enhance or to increase the covered field. As you see, the traditional colonoscope cover about 170 field of view, whereas the full spectrum endoscopy covers 330 field of view. Okay, in the beginning of its discovery, there was a study that proved the benefit of it regarding the adenoma detection rate, but with time the question appeared that it may not be extremely important regarding the adenoma detection rate. And also one of its disadvantages that it's costly, so it is limited a little bit. When dealing with difficult exam, we said we have different maneuver, changing the position, abdominal pressure. The ovary tube, you see, this is a tube actually, ovary tube. This is a tube placed over the, like the cylinder technique when inserting a jugular vein. Actually, this is a tube that is more stiff. We can insert it, but of course with the advent of the stiffness rule, we talked about it, we can control the stiffness of the colonoscope, so its need is not that important nowadays. One of the procedure that can help us is the cap assisted. Actually, it's a cap attached to the tip of the scope. Again, it's not yes, this it's written here that can be used to increase adenoma detection rate, but this is controversial regarding the Position changing, we already talked about how the changing of the position can help us, especially for example in the descending and the cecum, the patient can be put in a prone position. But remember that the patient may be sedated. Changing him to left, right, supine position in the transverse colon can be helpful. Abdominal pressure. We already said that it's mainly needed in the sigmoid, and this is the direction of the pressure above the umbilicus and toward the left iliac fossa. This is the direction when we have loop N or alpha loop in the sigmoid, and it's a suprapubic pressure for sigmoid, and upper abdomen from upper abdominal pressure if we are talking about the transverse colon. Okay. Incomplete colonoscopy. Okay. Incomplete colonoscopy should be completed. And we, as you see, the incomplete colonoscopy range from up to 25% by different reasons. We should ask ourselves why it is incomplete. Is it due to inadequate bowel preparation? If so, one of the strategies is to repeat the colonoscopy the next day because the patient is partially prepared, so we can give him additional bowel preparation and to get benefit of the previously partial preparation. Okay. In this case, imaging and radiological study usually is not the choice to proceed for imaging study because most of the specific imaging study require a kind of bowel preparation. If it is due to inability to reach the cecum, so by different reason, so we can, for example, change the level of anesthesia from moderate anesthesia or conscious anesthesia to deep anesthesia. This is one of the solution. If we can use a smaller or larger colonoscope caliper of the colonoscope, if it is the looping is extremely flexible, we can use larger caliper colonoscope. Or if the for example, if there is obstruction and the lumen is narrow, we can use a smaller colonoscope. Of the other modality is to use the carbon dioxide or water insufflation technique that we discussed previously. Okay, if it is due to loop, we can use the fluoroscope. The fluoroscopy, actually, it's while performing the colonoscopy, we take a dynamic X-ray, and so it will guide us in detection and prevention of the formation of the loop. Another technique is to use, if it is due to loop formation, we can use the double balloon colonoscopy or balloon endoscopy. It could be single or double balloon, as you see in this picture. Here is in the sigmoid and loop. By using the balloon endoscopy, you can see that it's actually, and here in the sigmoid, due to the omega loop, we use the double balloon. It's actually fix the colon and the skull. Okay, what else? If it is due to, for example, for malignant obstruction that will require surgery, so we can go to surgery and simultaneously with colonoscopy to evaluate the proximal lesion of the obstruction. As you see here, this is actually intraoperative endoscopy. Okay. We can use, if the previously mentioned modality fails, we can use the double contrast barium enema. This is the double contrast barium enema. Nice modality. The double contrast means that we use positive contrast. This means we use barium, and it's two imaging, and we use After evacuation of the bowel, we use a negative contrast. This is the use of gas. Preferable to use CO2. Just I'm explaining what does double contrast barium enema mean, because in the past I thought, for me, I misunderstand. For me, double contrast was the use of oral contrast and lower contrast. No, this is the use of barium, usually contrast, and the gas contrast. It will look like this. These days, actually, it is the double contrast barium enema is replaced by the CT colonography, or what we call it, the virtual colonoscopy. The virtual colonoscopy require bowel preparation, and so also maybe not always adequate, and it's not available in all centers. It's costly. Not all radiologists or enterologists can actually read the image and understand the image. It's need a kind of experience. Plus the CT colonography require to insufflate the bowel, which may be inadequate. You see here disadvantage of the colonoscopy. Of the disadvantage, need for another bowel prep, and it needs to distend the bowel with the use of insufflated room air or carbon dioxide. This is how the CT colonography or virtual colonoscopy looks like. Actually, to be honest, what is the best choice to go? To repeat the incompleted colonoscopy by another colonoscopy by an experienced endoscopist, or to proceed for CT colonography? No, the first scenario is the preferred. Some use that if the incomplete colonoscopy done, we cannot complete, they directly proceed, if available, to CT colonography. Why? Because the bowel is prepared, if it is again not due to inadequate preparation. Okay, in some cases, especially in the inflammatory bowel disease, we can proceed to MR colonography. It is preferred, especially in patients with inflammatory bowel disease. Okay, now let's move to the complication of colonoscopy. Okay, complication. Actually, these complications should be discussed with the patient even before starting the bowel preparation, and you should explain the patient that the benefit of having the procedure far outweighs the risk. These complications can be related to bowel preparation, or to anesthesia, or to the procedure itself. If we are talking about bowel preparation, so the classic complication when we use sodium phosphate is nephrocalcinosis and renal failure, and this results in removal of this option. If we are talking about polyethylene glycol, so nausea and vomiting, especially in these patients who have gastrointestinal dysmotility and elderly. Aspiration is also a risk in elderly and patients with gastroparesis. We said that the hyperosmolar or non-osmotically balanced bowel preparation usually associated with electrolyte abnormality. If we are talking about anesthesia, so there are some complications that indirectly associated with anesthesia, such as perforation, hemorrhage, abdominal pain, and stroke. These are indirectly related. This is because the patient is sedated, doesn't react, so the endoscopist can be more aggressive in some technique. Okay. Also, anesthesia can cause respiratory depression and cardiac depression, and over sedation can lead to respiratory depression and hypotension and hypoxia. Of course, if we are talking about propofol, so respiratory depression and even cardiac depression, which will lead to hypotension. Vasovagal attack occur due to the distension of the bowel, due to the traction of the bowel mesentery, due to looping of the colonoscope. Sorry. They are usually self-limited, but if recognized, you have to stop the procedure, try to reduce any loop if there is any loop, and try to aspirate the air which you already insufflated. Sorry. Okay, as we said, most of the vasovagal episodes are self-limited. Okay, true cardiac arrhythmia during colonoscope is usually uncommon, and these may be related to the bowel preparation. Okay, the vast majority is also self-limited. What else we have? Okay. Over sedation can mask. Okay, we said how it's associated with perforation. And what else? Of course, be careful about the positioning of the patient. It's not preferred to put a sedated patient who is hardly can protect his airway in a supine position. So you should avoid supine position. 2. Complications that are related to the procedure itself. Okay. Procedure complication, perforation, bleeding, splenic injury, infectious complication, post-polypectomy syndrome. These are related to the procedure itself. Perforation, it's rare, up to 0.8%, higher, of course, with therapeutic colonoscopy, and a little bit higher in patients who are going to undergo polypectomy. Okay. Okay. The perforation can be due to direct trauma by the endoscope or by the loop itself, and it could be due to paratrauma or distension of the bowel. If we are talking about direct trauma, so perforation can be due to direct trauma, can be due to paratrauma or distension of the bowel, and can be due to therapeutic procedure. For example, post-polypectomy or using coagulation and full thickness injury, which will ultimately lead to defect in the bowel. This is an example of perforation due to therapeutic procedure. If we are talking about the direct trauma, so it's most common to be in the sigmoid, the rectosigmoid junction, and we know that there we use the slide by technique, which is a big risk factor for the for perforation. Okay. How the perforation by direct trauma in the sigmoid? We said slide by technique. Also, if we are trying blindly to navigate the lumen of the bowel, or we have angle, or if we miss the exact lumen by a diverticula. The diverticula can have a stoma or that is large, that may mimic the the true lumen. Okay. These perforations are usually in the proximal part of the bowel. Of course, there are risk factors for perforation related to direct trauma, for example, severe diverticular disease, severe inflammatory bowel disease, ischemic colitis, history of previous surgery. For this, we can, in these risk factor, if these risk factors are present, we can use, for example, the pediatric scope, a smaller scope with a less. And of course, we have to be gentle in such risk factor. And what also, of course, everything should be done under visualization before advancing the scope. Okay, other type of trauma, we said the para trauma or over distension, which mainly occur not in the distal bowel or the rectosigmoid or the sigmoid, it occur in the proximal bowel, in the ascending and the cecum, as there the thin wall, we have thin wall in the ascending and cecum. Okay. Of course, this cause of perforation, the paratrauma, is reduced by the using of carbon dioxide insufflation. Also, paratrauma can occur if we are trying to put a stent in a distal lesion. This is because the proximal lesion is already distended with minimal air insufflation. And we know that the cecum with the highest diameter, according to Laplace law, it will perforate easily. Okay. What else? The endoscopist should understand that incomplete or aborting or abandoning a difficult colonoscopy is not a failure. He should stop. He shouldn't risk. He shouldn't take an unnecessary risk just for to sake a pride or ego. Difficult, abort the procedure, stop the procedure, cancel the procedure. Okay, we said incomplete colonoscopy is not failure of the colonoscopy. The perforation can be actually evident through the procedure itself. This is by noticing a defect in the bowel wall or the fat, or what we call it, the extracolonic fat. And the presentation is usually severe abdominal pain. You can see here the colonic perforation may be evident during the procedure itself, and this is by seeing the defect or visualization or the visualization of extracolonic fat. This will present as a severe abdominal pain after the procedure. If we have suspicious of perforation, stop the procedure, deflate the colon, and obtain an X-ray. And okay, I can't control the noise in the background actually. Okay, you can see this is an X-ray that shows an air under diaphragm, and you can see in the CT, this is a post-colonoscopy CT which shows pneumoperitoneum. Okay, those perforation who are detected early, for example, immediate after the colonoscopy, have better prognosis when we compare it to perforation that are recognized late. Okay, and even the perforation that are detected early after or immediate after colonoscopy can have a non-operative success of non-operative management. The management actually depends on the etiology, and the patient clinical condition. For example, if we have diffuse peritonitis, we should emergent exploration. Okay. The preferred, if we are going to surgery, so it's preferred to proceed to laparoscopic approach, and unless it's contraindicated. If we have, if we have, especially in those who present early or detected early or immediately, and we have good bowel preparation with less contamination and patient stability, we can proceed to non-operative management by using antibiotic and keeping the patient nil by mouth, and the non-operative management in this patient may be high up to 90%. Operative management, laparoscopically or open, we can either primary repair or resection and anastomosis. If we, other modality of treatment, that if we detect the perforation while performing the procedure, for example, defect or extra colonic fat is seen, so we can proceed to endoscopic treatment in a form of, as you see in front of you, clipping. Here is a defect, and you can see the clipping and even suturing endoscopically, as we will see. No, this is in the endoluminal lecture. This is a defect, and here we have a clip button. Okay, this is regarding the perforation, the bleeding. Okay, bleeding can occur during diagnostic colonoscopy, and this is rare, up to 0.3%, or it can be post polypectomy, which is a little bit higher, up to 6 centimeter, and this depends on the size of the polyp itself. We will see in the next few seconds. If it is recognized or evident immediately post polypectomy, so it can be managed immediately endoscopically using a clip. As you see, this is post polypectomy bleeding. They use a clip with or without cauterization, with or without epinephrine, diluted epinephrine injection. Delayed bleeding or delayed post polypectomy bleeding up to 1 week, actually there are many risk factors for delayed bleeding. Of them is the size of the polyp, especially those are more than 5 centimeter. We will see in the next few seconds. Other risk factor for delayed bleeding, or in general post polypectomy bleeding, thick stalk, right colon location, the using of anticoagulation, cardiovascular disease, and hypertension. Okay, as you see, this is the size and the percentage of the bleeding. You can see that up 0.4% for polyp that are less than 10 millimeter or 1 centimeter, and up to 6 for those who are near the 3 centimeter, that are near the 3 centimeter. Okay, in the past, while taking biopsy, they use the hot biopsy. Hot biopsy means using electrocauterization to remove the polyp or to remove the lesion. In contrast, we have the cold biopsy. This is, we do not use the cauterization. They think that this will control post polypectomy bleeding, but that was not correct, because hot biopsy is associated with delayed bleeding due to burn that can ultimately progress to full thickness and reach the vessels and causes and reach the submucosal artery, which will present as a delayed bleeding. So hot biopsy is generally not recommended. We will discuss it in detail in the endoluminal surgery lecture. Okay. How to manage post-polypectomy bleeding and in general lower GI bleeding. First of all, resuscitation, and we have a separate lecture of how to manage lower GI or lower GI bleeding, unstable resuscitation, history, prepare blood. You can see a nice lecture. We discuss the different modality, but what we want to say is about polypectomy and bleeding related to the procedure. What else we can manage? Resuscitation. What to do? Resuscitation. If the patient is with continuous bleeding, we can repeat the colonoscopy and do the previously mentioned procedure. Alternative technique is to go to angioembolic immobilization, and usually surgery is rarely required. Post-polypectomy syndrome, what do we mean by post-polypectomy syndrome? It is a constellation. It's gathering of symptoms together. These include abdominal pain, fever, leukocytosis, but without evidence, without radiological evidence of perforation after polypectomy. So, patient underwent polypectomy, present with fever, abdominal pain, with peritoneal sign, with leukocytosis. You suspect perforation, you do X-ray, no radiological evidence of perforation. Okay. This is usually due to the transmural burn that can be caused while performing the polypectomy. Where is it? You can see here that's caused by transmural pain to the bowel wall. Okay, with localized peritoneal sign and no radiological evidence of colonic perforation. Okay, the risk is increased with endoscopic mucosal resection. What do we mean by endoscopic mucosal resection? And also with endoscopic submucosal dissection. We will discuss this modality in the endoluminal surgery. It's removing the polyp with the mucosa surrounding, or even with the submucosa. It's of course with submucosal dissection higher than the mucosal dissection. Okay, typically the patient presents with pain 1 to 5 to 2 to 5 days following the colonoscopy, with fever, pain, and localized peritoneal sign. The clinical picture will mimic perforation, but again with no free air on diagnosed on radiological study. This, how do we manage? We manage it with IV antibiotic, with IV fluid, with bowel rest. No rule for surgical intervention here. Rarely the transmural burn, which we talk about, can progress to full thickness perforation, and the radiological or the CT feature of post-polypectomy syndrome, these include mural thickening with enhancement pattern, mural defect filled with fluid, and inflammation in absence of extraluminal air. Okay, this is post-polypectomy syndrome. Let's move to Splenic injury, how the spleen could be injured during the colonoscope. Okay, yes, the splenic injury is rare, and how the spleen could be injured during colonoscopy, it's usually due to the traction of the bowel wall and avulsing the splenocolic, as you see in this picture. When you move the colonoscope, attraction to the splenic flexure can cause avulsion in the splenocolic, and you see here we have a laceration. The most common pattern is to have subcapsular hematoma, but even splenic rupture and hemperitoneum is also seen. It's more common in female, it's more common in patients who undergo surgery. Okay, non-operative, yes, as blunt trauma, we can try non-operative, but unfortunately, in cases of splenic injury due to colonoscope, they are more likely, or the majority will undergo operative treatment. Okay. Of course, if the patient is stable, we can try the splenic artery embolization. Infectious complication related to the colonoscopy. Okay, bacteremia can be up to 4%, but infectious complication is rare. Even, we already discussed that, for infective endocarditis, in a low-risk patient, we shouldn't use prophylactic antibiotic, but in a high-risk cardiac condition, it's recommended to use antibiotic. Okay, what else regarding the infectious complication? The agent that can cause the contamination are those bacteria that have the ability to form a biofilm in the inner channel surface, so they will be more resistant to the decontamination. Of this agent is Salmonella, Pseudomonas, and Mycobacterium. Also, Klebsiella, Enterobacter, Serratia, hepatitis B and C are reported. The risk is usually 1 in 1.8 million colonoscopies. So, okay, so the surgeon or the endoscopist should be familiar with the cleaning and processing process of the colonoscope. Okay, cleaning or processing the endoscope, actually it's more associated with duodenoscope, and we said the rate is 1 infection per 1.8 million procedure, and actually it's advised the processing to be a multi-step process. Start with pre-cleaning of any gross contamination immediately post the procedure. This is to prevent the formation of biofilm and test if there is any leak in the device itself. Manual cleaning, as you see here, manual cleaning with high level of disinfectant, and also the final step is to inspect, visual inspection, that we have completed the processing before storage. This is an instrument for processing the colonoscope, and we can use an automated endoscopic process as in this picture, and it's recommended to do surveillance culturing. This is a culture probe, and he's taking a culture from the endoscope to document any organism or contamination. Recently, there is a, let's say, financial study about the benefit of this possible flexible endoscope. Okay, we reached the last or the end of our lecture, we will now talk about an important step in this lecture, and this is a quality measurement. How we can say that we perform good procedure, high quality procedure, and according to which parameter. Okay, what parameter we can use to detect the quality of the colonoscopy? Actually, we have many parameters such as the cecal intubation. But if you remember, we said that incomplete colonoscopy doesn't mean failed colonoscopy. You should struggle against your ego and do not put the patient on additional risk and trying to intubate difficult part of the colon. So this is not reliable enough. Photo documentation, screening interval. The more short the screening interval, this means that the quality of the colonoscope is not good. Bowel preparation quality. Bowel preparation quality, if you remember, we talked about the Batson preparation score, and you can see here the color of the stool after bowel preparation. Here we have the yellow and clean urine-like stool. It is the desired color of the stool before the proceeding to colonoscopy. And the last two measures, the most important, and we will talk about them, is the withdrawal time and the adenoma detection rate. We will talk about them. You can see here that cecum intubation, to say this is a good quality, so the cecal intubation should be more than 95 during screening colonoscopy. And adenoma detection rate, again, we will talk about that, but it should be more than 25% in men who are older than 50 years old who are going their first colonoscopy. Incidence of complication, for example, perforation, less than 1/1000 cases. Again, the parameter, these are the most important. Adenoma detection rate more than 30 in men who are more than 50 years who are undergoing their first colonoscopy. In men 30%, in women 20%, on average 25%. Withdrawal time more than 6 minutes. Cecal intubation, we should reach the cecum in about 95% of patients for screening colonoscopy, and more than 90 for all colonoscopy. Adequate bowel prep, 85% of the patient should be adequately prepared to say that this is a good quality colonoscope. What do we mean by withdrawal time? Is the time needed to or spent from reaching the cecum or the terminal ileum, the last part of our exam, till the end of the procedure, pulling the colonoscope without any additional maneuvers. And actually it's at least 6 minutes, without additional maneuvers such as polypectomy or biopsy. The more the withdrawal time, the better the quality of the colonoscope. And you can see here in this picture they compare between 6 and 9 minutes withdrawal time. Here in 6 minutes you can see the adenoma detection rate is 27, whereas 9 minutes it is higher. So, and also serrated polyp detection is higher in 9 minutes. So 9 minutes is better than 6 minutes. But good colonoscopy withdrawal time is more than 6 minutes. Okay. Uh, Disadvantage of this parameter that it can be artificially manipulated. The colonoscopist or the endoscopist can stop during the procedure to increase the withdrawal time, and this is why this measure actually fall out. How the colonoscopist can artificially manipulate this measure, it's actually by, for example, incorrectly noting the time of cecal intubation, repeated evaluation of the same suction, multiple time, or simply parking the scope in the rectum until the desired time have been documented. So it's not dependent, it's not a very good parameter to detect the quality. Adenoma detection rate. Okay. Adenoma detection rate is better, excellent, and better than withdrawal time. And it's defined as the fraction of patients who are over 50 years or older undergoing first time primary screening colonoscopy and have one or more adenoma detected. So, what do we mean by adenoma detection rate? The patient should be over 50, first time colonoscopy, screening colonoscopy, and who have at least one adenoma detected. We said it is an excellent one, and the benchmark that we have to remember is that it is 25%, should be more than 25% of these screening colonoscopy. 30 for male, 20 for female. Okay, why we do not use not adenoma detection rate but malignancy detection rate? This is because the concept of screening is not to look for malignancy. If we use malignancy detection rate, some colonoscopists will delay colonoscopy until malignancy will develop, and this will reflect bad on the patient status. So adenoma is more logical because adenoma is border between the benign and the malignant condition. And why not to push? Why not to use polyp detection rate? This is because this will push endoscopists to remove unnecessary polyps from the colon, and so it will not help. Of course, there is a drawbacks. There is a disadvantage for the colonoscopy. Of these, that the definition of adenoma detection rate, the patient should be over 50, first time screening. Actually, we have just strict limited data to collect. This is one. Another drawback, you remember that we said that the detection of at least one adenoma. So this may result that the colonoscopist, if he detects one adenoma, he will take it, document it, and rush, and he will go back. So what about the remainder part of the colon? So this is one of the drawback. As you see, some urge that expanding, none of this. Okay. What else before talking about? This is the endoscopist will rush to close the exam after the first polypectomy was performed. Okay. For this reason, some center use the adenoma per colonoscopy as a quality measures. How many adenoma you collect during your first time screening your a first time screening colonoscopy for a patient over 50. This will fight against the detection of one adenoma and withdraw the colonoscopy, called the adenoma per colonoscopy or APC. Okay, so these are the quality measurements. The best is adenoma detection rate. Adenoma per colonoscopy is also an excellent. Withdrawal time is good, but not as good as adenoma detection rate and the other modality we are already discussed. Let's talk about the last part of this lecture, training and simulation. Okay, training and simulation. Actually, we said when we start to talk about colonoscopy that this procedure is you get experience by practicing, not only theory. And practicing have level. We can start with dry labs such as virtual reality simulators. You can see here a simulator for colonoscopy. Then you can move up and go to wet lab. We mean by that the animal cadaver training and live surgery on human. Of course, the gastroenterologist and gastroenterology fellow have more exposure, more experience when compared to surgeon. I know that some surgeon even not interested in such approach because they say we have our surgical procedure that we can spend our life without getting full proficiency in them. So we have our job that and time doesn't not enough to proceed for endoscopic procedure. Sorry for talking about that, but for me, it is one of my interests, and I believe, with God willing, that I will be professional in the endoscopic approach within the next few years. Okay, I said I'm sorry for that, but again, if we are talking about America, so the American board surgery now says that it's mandatory for the resident to at least train on a simulator for endoscopy. Not only the general surgery specialist, not the only the colorectal surgery fellow, but also the surgical resident. And there is an flexible endoscopy curriculum. I understand it as a logbook that the resident should complete before the residency program, and he should be familiar with the basic GI endoscopy. Okay, of course, the training should be under supervisor, and you can see here that colonoscopy for general surgery resident they should perform at least 50 colonoscopy under supervision, and colorectal surgery fellow should perform at least during their fellowship program 140 colonoscopy, of which 30 must be interventional. If you ask me, at the end of my fellowship program, how many colonoscopy did you perform? I will tell you that it is null, zero. Okay. Uh, Unfortunately. Okay. What else I can add? Sorry for disturbing you. You can see here the simulator. We said that actually this is done by supervision and experienced colonoscopist, the training program. And here we have a colonoscopy score sheet in which they determine your level of experience. For example, how do you navigate the scope? How do you use the tip deflection, advancement withdrawal, the Turk? How do you some strategies such as patient positioning, abdominal pressure, insufflation, suction, loop reduction. How do you deal with how do you keep clear endoscopic field using insufflation, suction, irrigation, etc. Instrumentation, can you take biopsy, and etc. Quality measurement, how do you take care of the patient comfort, and how do you completely assess the mucosa or evaluate the mucosa. We reach the end of this lecture. Thank you for watching till the end of this lecture, and our next lecture we are going to talk about endoluminal surgery. Bye bye.